Hello everyone, this is CSF Rhinorrhea, presented by Dr. Hazem Muhammad Abdel Tawab, Professor and Consultant of Otorhinolaryngology, Head and Neck Surgery, Faculty of Medicine, Cairo University, Egypt. Actually, CSF Rhinorrhea is one of the very important topics that we face in our OPDs and in our operating theaters. So we are going to go in details about its etiology and how to diagnose CSF rhinorrhea and how to deal with them. So starting with the first slide. What is actually CSF rhinorrhea? In order to understand this, we need to see this picture. This picture here is showing the sinonasal cavity and showing the brain. Between both there are different layers. Some layers are there. So in order to have a CSF leak in the nose, we need a breach here. So what is that? This is the subarachnoid space, which contains the cerebrospinal fluid. It is between the arachnoid mater and the pia mater. This is the dura mater. The space between dura mater and arachnoid is a potential space, which is the subdural space, while the space between the dural layer and the skull bones is called the epidural space, as we see in the picture here, and it's also a potential space. So in order to have CSF in the nose, it means that we need a defect. This defect will communicate the subarachnoid space with the nasal cavity. So actually it means a breach in the dura, it means a breach in the skull bone, it means a breach in the mucosa and the periosteum. So all of these need a breach so that the CSF fluid will go, the CSF will go from the subarachnoid space into the sinonasal cavity. For the nose, the weakest area is the cribriform plate, where there is actually no dural layer, as it is mentioned here. So the sources actually which can get CSF is clear in this picture. So CSF can come in the nose through the frontal sinus, through the ethmoids and the cribriform plate, through the sphenoid sinus, and less commonly this is the last route, which is coming actually not from the anterior cranial fossa, but it's coming from the middle and the posterior cranial fossa. So how comes that a middle and posterior cranial fossa CSF comes into the nose? Usually it's coming into the mastoid and the middle ear through a defect there, and through the middle ear cavity to the eustachian tube. It means that it's going to reach the sinonasal cavity through the eustachian orifice here. And this is of utmost importance because of what? Because in examination of CSF rhinorrhea, you need to examine the ear. Why I need to examine the ear? Because sometimes some of the traumatic conditions might lead to a defect which is not in the nose but in the ear. Actually it is less likely, but it is there. So we need to examine the ear well so that we can differentiate between CSF rhinorrhea and pseudorhinorrhea, which is coming from the ear through the eustachian tube. So it's coming actually from the middle ear and the mastoid. So CSF itself is not a great problem, but the main problem is the risk of meningitis, because actually it is the route for infection or infective organisms to reach to the meninges. The overall risk of meningitis might reach up to 9.8%, which is actually a very huge number. So some of the authors are saying that it's better to manage the surgical repair even if there is no active leaks. However, most of the authors are saying that there is no need to manage the CSF as long as this is not having any active leaks. But due to the risk, the actual risk of meningitis, actually it's better to go for the surgical repair even if there is no active leak. So what is CSF? What is the cerebrospinal fluid? The cerebrospinal fluid is that fluid which is produced by the choroid plexus in the lateral third and fourth ventricles of the brain. In total, it is about 123 milliliters, and it's formed in the rate of 0.35 to 0.4 milliliters per minute, which means that about 50% of the CSF is going to be replaced in 5 to 6 hours only. So it means that it's not the same content, but it is renewing every now and then. So this is the cerebrospinal fluid. There are many classifications regards the CSF rhinorrhea, but the classification I'm going to adopt here in my presentation, it will be according to the onset and course. So according to the onset and course, we have the acute CSF rhinorrhea and we have the chronic CSF rhinorrhea. The acute, which means that we have an acute onset of leak of cerebrospinal fluid from the brain, as we have said, from the meninges through the defect into the nose. So it's either spontaneous, which is actually due to idiopathic intracranial hypertension, or traumatic. And here is the trauma can be divided into two categories: the accidental, like road traffic accidents or falls or something like that, or the iatrogenic, which are going to discuss in details in the coming slides. So this is what we are calling the acute cerebrospinal fluid rhinorrhea. What about the chronic? The chronic, it means that it's going through long duration, and this could be either congenital, like a meningoencephalocele, like congenital defects. It can be also inflammatory, like fungal sinusitis, like osteomyelitis, or other inflammatory conditions, and neoplastic lesions or masses, which can erode the places that we have mentioned before, leading to the CSF leak into the nasal cavity. So discussing first about the spontaneous. So in our clinics, in our outpatients clinics, we are seeing that patient with a unilateral, because it's less likely bilateral, but however it is there, but it's mainly unilateral, as I have said, clear nasal discharge. Maybe some of us, maybe all of us have faced this problem. And now, how can I differentiate if this is only that rhinorrhea of allergy? Because if the patient comes to me saying that I have some nasal discharge coming from my nose, how can I suspect that this is CSF and not normal mucosal secretions or whatsoever? So the patient comes to you with saying that I have unilateral clear nasal discharge, intermittent, sometimes I have it, sometimes not. The presentation usually becomes unilateral, as I have said, which raises our suspicion. If that leak is continuous, usually the patient will tell you that he's having a salty taste according to its content. But we should not ignore that the first presentation might be meningitis. Like in this picture, there is a gap, there is a defect, as we see here. But in order to see the presentations, we should not ignore that the first presentation might be only meningitis. So this will be the first presentation. So, for example, if you have a patient, if you have been called for a patient with meningitis to rule out CSF leak, you need to attend that and you need to manage to know if there is a defect in the nose or there is a defect in the ear. So usually in the patients with the spontaneous leaks, usually it happens due to, as I have said before in the previous slides, idiopathic intracranial hypertension, which is usually common in females, usually common in OPs, however it can happen in anyone. And due to the fact that it is due to increased pressure, usually rarely resolves spontaneously. So actually it needs an interference and less cases or few cases that respond and close spontaneously without any intervention. This is for the spontaneous, as we see in the picture here. What about traumatic? As I have said in the classification, that trauma can be head trauma, like for example fall, like for example road traffic accidents, and can be iatrogenic. So in this slide, or actually in the coming two slides, I'm going to discuss about head trauma. For head trauma, actually it has been found that 39% of CSF leak can happen in the acute phase after trauma. This is a big number. like for example in any road traffic accidents, there is a possibility of CSF leak. If there is a possibility of CSF leak, it can happen 39% in the acute phase, which means the first week. Usually, most of the presentations can happen in the first 48 hours, but sometimes it can take up to 3 months after trauma. And here comes a question, why it should take that much late? As you see here in this picture, there is a fracture. You can see here in the picture, there is a fracture everywhere. And this, with the history, of course, it will guide you towards the diagnosis. The question is why it can take, or it may take up to 3 months after trauma to develop. The issue is with the fractures, there might be a large hematoma or something like that closes the way. So after resolution of that one, usually the CSF leak happens and you can see it. So in this picture, as you can see, also there is a breach here. There is a trauma here. How can I know that this is not a spontaneous? In this picture, this is a spot, actually spot diagnosis. Here you can see the picture of the trifine. There is some trifine marks. It means that this patient had fractures before and maybe some hematoma inside that needs opening. So in this picture, if you have a suspicion towards this one in the diagnosis, it should be traumatic rather than spontaneous. 85% heal spontaneously here because the picture here and the cause here is not due to raised pressure like the spontaneous, as we have said in the elevated or idiopathic increased intracranial hypertension or pressure. Here 85% might heal spontaneously with only bed rest. Sometimes a lumbar puncture to decrease also the pressure might help in resolution of the traumatic CSF leak. Again, what we are saying is that the mucosal growth usually delays that appearance of CSF leak. So in order to know that the history or the etiology is traumatic, you need to go very well in the history with the patient to know actually if he's having a trauma within the previous up to 3 months, as we have said, because if the trauma is up to 3 months, this cannot exclude it as a cause for CSF rhinorrhea. Again, we are speaking still about the head trauma as a cause of CSF leak. So less likely the healing can happen when? Actually, there are 3 conditions that less likely healing will happen, like more extensive trauma. For example, if that patient is having very extensive trauma, usually it leads to bigger fractures. Bigger fractures means bigger defects, means more leak. Sometimes with penetrating and comminuted fractures, penetrating wounds, and like bullets, maybe like knives, or comminuted fractures where there is loss of tissues, usually also the trauma is more. It means the defect is bigger. It means the fluid is more. Or direct to the cribriform plate. And this is of utmost importance because this is actually the most common site where the leak happens. So, meningitis. As we have said, meningitis, we should not forget, we should not neglect. Actually, it is the reason why we are moving to go for repair of the CSF rhinorrhea. So, meningitis, it can happen before correction of the CSF leak, and according to literature, it might reach up to 30% before going to that repair. The risk is increasing with the duration. Like, for example, if the leak is continuous and that patient had been ignored for some time, saying that, okay, we are going to do the surgery, it means that with every time you delay this patient, and you know that he's having a persistent leak, actually you are sacrificing what's going to happen is he's going to develop meningitis, of course. But however, we are going to stay with that word that antibiotic use is questionable. It is actually controversial to use antibiotics except if there is a doubt or there is a confirmed diagnosis of meningitis. Otherwise, the antibiotic use itself without meningitis being established, for example, some of the doctors are giving it as prophylactic. Yeah, prophylactic according to the literature, did not improve or did not postpone or did not delay the onset of meningitis. The issue is usually it kills the flora, which means that you are actually increasing the possibility of the gram-negative meningitis, which is actually also a big problem for the patient. So according to most of the studies, antibiotics should be used only if there is established diagnosis of meningitis. The second type of trauma is the iatrogenic, which is also considered very important because this is actually the work of doctors. So the most common operations where there might be a defect, like you can see, and this caused by the doctor, the operating surgeon, is the endoscopic sinus surgery. Any operation with the scope can lead, if that one is not skilled enough or less experienced, it means that he's going to cause that defect. Also in anterior skull-base surgery, sometimes with only mobilization of the vomer, sometimes with only mobilization of the middle turbinate, it might cause a crack, and this crack will cause the CSF Rhinorrhea to happen. And this is actually reaching from 0.1 up to 2.5% in endoscopic sinus surgery. But we need to see one thing. In the lateral lamella, which is the commonest site, usually it happens with less experience because working lateral to the middle turbinate, usually the junior doctors are working here with more safety. They are thinking that this is a safe place. But working in the roof, working in the area of the lateral lamella might cause very big chances of injury in the less experienced hands. But what about the big experienced hands? I mean the old doctors with experience. The problem actually comes here not in the lateral lamella because they know it well, but the problem comes with the posterior ethmoid roof. Why is that? Because it comes like a slope, as you see here. You're working the posterior ethmoids. If you are not taking care, if you are so much confident, then you are going in that direction, not actually respecting the slope. So actually the less experience usually happens in the lateral lamella, but with more experienced doctors, usually it happens in the this area where the slope happens, and the doctor is going like this instead of following the usual route of the sphenoid and the ethmoids. Sometimes again it is delayed. Why is that? As I have said before, if there is a hematoma after the injury, because most of this one is discovered during the operation itself. Like for example, if the doctor is working, he will discover the CSF leak. He can repair it in the same session, but usually or there is also a chance that it might be discovered later because of what is happening here. Might be there is a hematoma, small hematoma or small blood collection here that caused obstruction of the flow, and then when that one is resorbed, then you can find it some days later. So you need to follow the patient well after surgery. So how to diagnose cerebrospinal fluid rhinorrhea? The diagnosis actually is based on many things, based on your examination, based on your investigations. So in order to go, start first with your eyes, with the examination. Actually, what is interesting about the cerebrospinal fluid is the lots of signs that you can see here. The reservoir or the teapot sign. Actually, this is the word which raises the suspicion when the patient comes to your room in the clinic. He will tell you like, if I'm going to lean forward like a teapot, it means that I'm leaning forward, the fluid comes. So it's like a teapot sign. He leans forward and then the fluid comes. As long as he is staying in the position, the normal position, nothing's happening. But if he comes leaning forward like a teapot, you will see that fluid coming from the nose. It's also called the reservoir sign because usually we are using that in our surgeries. If, for example, you want to see more leak, you will tell the patient to lean in a position where the head is up for some time, and then you are going to tell the patient to lean forward. Then you will see all the fluid which has been collected as a reservoir coming down. This is the first sign, and you should ask about it, and you should have the doubt that this is CSF if the patient mentioned that. There is another sign usually we are noticing in traumatic conditions, like this is the halo sign or the target sign or the double ring sign. As you see here, if this is blood coming from the nose, it will be only blood. But if you see that blood trickle, for example, on a piece of dressing, and you will see that yellow ring around the blood, yellow ring means that some faint fluid is there, yellow in color, it might raise the suspicion that this is a CSF mixed with blood. So this is also very important, especially in the traumatic conditions. Handkerchief sign. Most of us know that from our junior life in residency. Because of what? Because we know that if we are going to use the tissue or the handkerchief, and if I'm going to just wipe my nose, because of the mucoid secretions and the mucin in my nose, this one will be stiff. The handkerchief will be stiff because of the mucin, because of the mucoid secretions. But going to the CSF fluid, if that patient is having runny nose and he's trying to make it dry or wipe it with the handkerchief, this handkerchief will never become stiff. This is because of what? This is because that there is no mucin, there is no mucoid secretions in the CSF. So if you see the handkerchief all the time is wet, it's not stiff, so it means that this is mostly a CSF leak. This is again very important if you are going to examine and listen to the history of your patient. And definitely you are not going to forget about the wash sign. What is the wash sign? It means that you are working, and it happens in the iatrogenic lesions. You are working in, for example, endoscopic sinus surgery or any lesion in the nose, and you're working with your scope and you caused that injury. All of a sudden you will find that instead of telling your assistant to wash the nose for you, you will find a spontaneous wash. No need to irrigate saline by your assistant. You will find like all the tissues there are being cleaned by themselves. Why cleaned by themselves without irrigation? Because mostly you have breached the skull base and that CSF fluid is coming, the CSF leak is coming down. It's going to clean the nose for you. Whenever you see the nose clean and there is like fluid cleaning the nose without you asking your assistant to clean the nose by irrigation, it means that there is a breach and there is a CSF rhinorrhea. So if you, by examination, have the suspicion, we should go for the endoscopy, which is actually can diagnose the site up to 36% of cases if you prepared your patient well. But again, the specific test that we should search for is collecting this fluid. If you can collect this fluid and going for the beta transferrin, which is very specific to the cerebrospinal fluid, the beta transferrin, you need to collect that fluid and send it to the lab. If comes that there is beta transferrin in that fluid coming from the nose, it means that it is CSF rhinorrhea, and I'm coming to that in the coming slide because it actually the beta transferrin holds a very high sensitivity and specificity to diagnose cerebrospinal fluids. Also, sometimes we need the imaging, like for example the CT scan to show the bony defect, especially in traumatic cases where you can see the fracture line, the fractures, you can see the bony defects causing the CSF, and also the MRI, especially the T2 cuts, because this T2 cuts usually will show the fluid in a very white color. So whenever you see that one, it means that there is a fluid coming from above down, coming from that defect into the nose. So actually these are your arms of diagnosis or methods of diagnosis. So we are going to discuss them one by one. For example, beta transferrin. It should be kept in that white topped bottle or that one. It means what? It actually is a very sensitive test. 99% can diagnose the cerebrospinal fluid leak. Some of the authors are saying that actually it is it can also found in the blood in some cases, like for example chronic failure, chronic liver failure, sometimes in rectal carcinoma. It is found in the blood, but actually by going into the literature, it doesn't give a difference In diagnosis, beta transferrin is very specific to the CSF fluid. Whenever you find it, it means that this is the fluid coming from the nose. It means it is CSF. It is too specific that only 2 drops can be enough. Also, you can give that bottle to the patient to collect the fluid at home, because when he comes to your OBD or your clinic, it is not necessarily that he can give you the fluid in the same time. Usually, when he goes home, usually when he leans forward at home, usually he can or he might be able to collect the fluid. But the problem is that if you allow your patient to keep that bottle with him at home to collect the fluid for you, usually the patients, if they collect, they are going to stay till the other day, or maybe 2 days till they come, or they have a chance to come to the hospital to deliver the bottle for the lab assessment. Actually, this is so wrong because of the rapid degradation. So you should tell your patient, instruct him clearly that this one should be processed very rapidly. Whenever he's having the bottle, he should get it immediately to the lab. And it should be repeated if negative. Like, for example, in order to say that beta transferrin, the CSF, is not there, I need to do this one. If negative, I need to repeat it. If I have it negative, I need to repeat it. It means 2 times at least negative to exclude it by the beta transferrin test. But there is one thing also for you as a doctor, depending on your clinical expertise, is that if it is it's difficult to collect, like if the patient comes to you after a while, like 1 week or 2 weeks, he's keeping the bottle and he cannot give you only 2 drops, this will raise the doubt of CSF leak, because CSF leak is there. If it is there, actually, he will be able to collect it within a very short period because of the reservoir sign, as we have said before, maybe because of the continuous leak. But if it is difficult to collect, it means that it is mostly not a CSF leak. So in the diagnosis, and going again with the imaging techniques, there is the CT cysternography. Actually, it was being done before with the metrizamide or the new dyes like iohexol, but actually there are some limitations for that. It's considered invasive because of the reactions which are happening as headache, as nausea. Sometimes with inactive leaks also, it will not give you the better diagnosis or the perfect diagnosis. But going for CT scan high resolution, 1 to 2 millimeter cuts, or you can name them thin cuts. Please don't say whenever you are speaking with your radiologist or your colleague radiologist, do not say minimal cuts. It is a thin cut. Thin cuts means 1 to 2 millimeter cuts, and go from my clinical practice, I'd go with the 1 millimeter cuts. It will show well where is the defect. There is one thing that it will show the bony defects if large enough, and can also help in diagnosing fractures, as I have said previously. But also it can help you if you want to see any posterior frontal wall defect or a sphenoid cut. But here you will look at the axial cuts, of course. But the limitations, if there are fractures, multiple fractures, or there is previous surgeries, then it might just make you misinterpret the CT scan, and this also will not help you in detecting where is the bony defect. MRI is very useful. Actually, it is one of the helpful methods, and one of the diagnostic tools, together with the beta transferrin mentioned before, to diagnose CSF Rhinorrhea. It's very helpful in very, very small defects, as we see here in this picture, where the CSF, as I have said, it's the T2 weight pictures, because all the fluids will appear in the white color. So you will see in the nose, coming into the nose, there is the fluid through a very, very small defect. Or you can see that big amount of defect, which may raise the suspicion of meningoencephalocele. So please, whenever you are asking for MRI, together it is with the beta transferrin, they are going to help you well in going for the diagnosis. So in the literature also, and in our clinical practice, there is the intrathecal injection of fluorescein. The problem with fluorescein is what is the reaction. It should be tested before it is used. Actually, not the literature. In the literature, if you are going to search for, you will find that there are less literature saying or preferring to use the intrathecal injection because of, as I have said, it needs a skin prick test to see if there is a reaction or not. It can cause reactions, very allergic and anaphylactic reactions. It should be used before anesthesia. If you're going to repair, please don't let your colleague from the anesthesia to anesthetize the patient before giving the intrathecal injection first, because if he's doing the skin prick test, for example, and there is a reaction, then he should not continue with the intrathecal fluorescein, and the anesthetic doctor should not give anesthesia to the patient depending on the giving the fluorescein before the test. So all the time, please, whenever you are going to use the intrathecal injection, please don't give it after anesthesia, because the patient might have a very severe anaphylactic reaction, and then you cannot manage that. So please start with the skin prick test. If you are going to use that one, it should be tested before anesthesia. And if happens that you cannot see with the scope after it's given, you cannot see with the scope, even also putting the blue filter here also will help to see that color. It will be seen so clear. Even if you cannot see it, you can make the head down for about 45 minutes to collect, as we have said before, making like a reservoir, and then changing the position of the head will show you the fluorescein coming. You are injecting intrathecally, but there is a limitation, of course, here, that if that patient is having a previous spinal surgery or he's having a reaction or side effect due to the fluorescein, you should not depend on this method. Actually, the methods which are applicable or more applicable right now are the beta transferrin, CT scan if it's many or large defects, and the MRI to exclude any small defects. So again, we are going to speak about the antibiotics. As I have said in previous slide, that antibiotics are only given in established meningitis. Like if you're having a diagnosis of meningitis, you can give. Also, I have said that it suppresses the flora. It means that actually you are not killing the organism, but you are giving a chance for other organisms to cause, like gram-negative, to cause gram-negative meningitis, which means that you increase the resistance to antibiotics and still you did not abolish the chance of meningitis. So going to manage all what we have said now, the types that we have said, for example, spontaneous management here, I mean for the acute cases, management of a spontaneous CSF Rhinorrhea, which is actually, as I have said, mentioned before, it will not, most of the cases, it will not heal spontaneously. You need to endoscopically localize that defects and to exclude also other pathologies. You need to take the fluid, as we have said, by beta transferrin CT scan. High pressure symptoms after closure. Usually, if you have controlled that defect and closed it with your methods that we are going after a while, and then that patient had the high pressure symptoms, increased CSF pressure, and you measured that by headache, and you have seen the symptoms, and you have found that the high pressure symptoms, it means that this patient might also need a neurosurgical shunting, a neurosurgical intervention, because spontaneous is usually associated with elevated, as we have said, elevated pressure. It means idiopathic intracranial hypertension. For the head trauma cases, you need to wait for some time because there are some self-threatening problems. Like, for example, if that patient is having more problems of for example, is having some neurological insult, you need to wait for some time before going for the repair. So more threatening or more self-threatening problems, like I mean by self here, is the brain. It means that you need to wait for some time and then you repair the leak. But if you have a persistent leak and you are afraid that it's going to cause meningitis, then do not wait and go for the repair. CT scan here, as we have said, is very crucial to diagnosis. It will show the fractures and bony defects. Spontaneous closure of most of the cases can happen, as we have said before, because of some mucosal growth. But if persistent leak, it means that you should go for repair. Lumbar puncture is questionable here, but it can also help to decrease the pressure. Antibiotics, as we have said before, only they can help if you have the established diagnosis, and it can be corrected through endonasal technique, which is the endoscopic technique. Sometimes if it is big fractures and you need to go by double approach, like nasal endoscopic and also external to close the big defects. Iatrogenic. For the iatrogenic, if noticed during surgery, as I have said, by the wash sign, you should repair. And in this case, you should tell the anesthesia doctor that you are going to change the position to head down, so that it will be a very difficult position for you, but actually it should be the position used, because here you need to decrease the flow, and you need to see the defects, and you need to see how to repair it well. If it is noticed later, like we have said before, if there is a hematoma or something that later on becoming absorbed and you can see the CSF, then it means that you need to do the CT scan to know where is the defect. Now you are out from the operating theater, and the patient, by the second day, maybe you discover the CSF leak. Most of the small lesions which will appear in the CT scan can heal, but others, bigger, need repair. The approaches differ according to the technique, to the problem itself. So, for example, if it is coming through the cribriform plate, then endoscopic will be preferred. If it is the posterior wall of the frontal sinus, or the sphenoid, or maybe sphenoid, maybe in mastoid approach, it means that you will need an external approach. For example, if it's coming from the ear, you will need the mastoid approach, transmastoid approach, to close the defect in the tegmen of the mastoid or the middle ear. But if it is in the posterior wall of the frontal sinus, you need the external approach as well, with the endoscopic sometimes alone. Intracranial, it means if you are going to work in, for example, big fractures and you need craniotomy, but the craniotomy is having many problems, like persistent anosmia because of mobilization, and also there is a big chance of causing epilepsy as well. So the types and the position of grafts. Grafts are putting in layer on lay according to the situation, according to the size that you can see. We're going to discuss that in a while. You can use the fascia lata, you can use the temporalis fascia, you can use cartilage, some mucosa, sometimes the nasal septal mucosa. The fibrin glue is questionable between some of the doctors, but it is usually used. After that, you can put a pack of oxidized cellulose or BIPP bags. This will also help, but keep the packs for about 7 to 10 days after surgery. Most of us, or maybe some of us, are facing the fact that after the operation itself, in the same day or maybe in the next morning, you'll find some CSF, very, very mild trickle or minimal trickle around the back itself. So usually there is no need to panic, because these small leaks usually close with the back inside. After 7 to 10 days, you remove the back and everything will be okay after healing. So going with this algorithm to diagnose CSF rhinorrhea, you're going from the history first. If you have that history suggestive of CSF rhinorrhea, you're going with the tests, as we have said, beta-2 transferrin, nasaloscopy, and the high-resolution CT scan. If you find the beta-2 transferrin test is negative, you are going to retest again, as we have said before. If it is 2 times negative, then question yourself. Was I right in the diagnosis of CSF rhinorrhea? If you have still a suspicion that this is CSF rhinorrhea and you want to cut it short, then you are going with the T2 MRI, which will show very minor defects or very small defects, or you can go with the diagnostic fluorescein, as we have said, but before anesthesia. If there is positive beta-2 transferrin, you are going for what? The next step, you are going for either it will be a negative scope, like for example, you are having positive beta-2 transferrin. You are going to go for the, if it is negative, you are going to repeat it. If it is positive, for example, here it's positive, the first test, you have repeated, you found it in this case, if you find a positive beta-2 transferrin, what you are going to do? You are going to do the scope and the high-resolution CT scan. If the scope and high-resolution CT scan showed you positively that there is a defect, then you are going for the surgery, and you might use the Fluorescein lumbar puncture if there are multiple leaks before anesthesia in order to repair. But what if it is positive beta-2 transferrin and you have done the scopy and the high-resolution CT scan and you did not see the defect, like negative defect you have found? Then go for the T2 MRI. So in this one, you don't need the MRI because you have the positive defect, you have seen the defect with the scope and high resolution. Then go with the surgery and with the Fluorescein lumbar puncture if you are suspecting multiple leaks. But if after positive beta-2 transferrin, you did not find the defect by the scope or CT scan, then go for MRI T2. Then you'll go for the Fluorescein at the time of surgery, as we have said before anesthesia, in order to confirm the diagnosis and see that you have closed the defect well. This is for this algorithm, and we have another one. By the clinical history, if you are suspecting, you are going to tell the patient to do a Valsalva maneuver, or you're going to examine with the scope. This is the physical examination. You can confirm the CSF by going with the beta-2 transferrin. If you can localize the CSF fistula by CT scan, by MRI, by the CT cysternography, as we have said before, mentioned before, then most of the leaks, if they are small, can close conservatively. So you're asking your patient not to do forcible blowing of the nose, and let him to avoid straining. If this one failed to close the defect, then you are going for the surgical management. If it is an encephalocele, for example, if you find a encephalocele, then you are going to remove that the mucosa, overlying mucosa. You are going to resect that mass, and you are going to close the defect. Closing of the defect usually coming by onlay graft and fat obliteration. If the defect is in the sphenoid sinus, you are going to remove the sinus mucosa. You are going to do fat obliteration and onlay graft. If the defect is in the fovea ethmoidalis and cribriform plate, which is actually the most common, then if it is less than 3 millimeters, a small defect, then overlay technique is used. If it is bigger than 3 millimeters, then the onlay technique will be used. And as I have said before, you can use more than one graft. You can use the fibrin glue after that, and you can use the oxidized cellulose or the BIPP backing for 7 to 10 days. After the operation, what you are going to tell your patient, you are going to tell him to avoid forcible sneezing and to avoid straining and heavy lifting. This is so much important, not to raise the pressure and not to cause the graft to fail. One of the most important causes of failure is increased pressure, as we have said before, and in this case you might need the help of your neurosurgical colleague. Is going to do a shunt ventriculoperitoneal, for example, to decrease the CSF pressure. The take-home message from my presentation today is clinical assessment is needed to fulfill the diagnosis. This is guided by your suspicion and by the patient's full history. So the most commonly used methods for diagnosis will be the beta-transferrin, which is very crucial and very specific, as we have said before, together with the imaging techniques, especially the MRI, which can offer you a great help in detecting very, very small lesions. Endoscopic repair, actually, it is the mainstay in the CSF leak according to the common causes and common sites. But if there are multiple and large defects, you might need a craniotomy approach, putting in consideration that it will have unfavorable side effects like anosmia and maybe epilepsy. This is the take-home message for this lecture today about CSF Rhinorrhea, and I hope it reached well to all of you, and thank you so much.